Hello and welcome back to the channel FMG to MD. Today's topic will be AV blocks. Studying the normal physiology first, the normal impulse is generated in the SA node. Via atria, it travels and comes down to the AV node, then to the bundle of His, and then via bundle branches, it is given to the ventricles with the ends of Purkinje fibers. This is the normal physiology. But if there is any defect in this normal pathway at the level of AV node, that is AV nodal pathology, or below the level of AV node, there will be hindrance in the normal conduction, that is known as AV blocks. There are three types of AV blocks: first degree, second degree and third degree. Looking at the normal ECG first, this is a normal ECG of PQRST. The normal PR interval consists of 3 to 4 small squares. One small square is equal to 0.04 seconds. So 3 to 4 small squares will be of 0.12 to 0.16 small seconds. So this is the normal duration of a PR interval. Any duration more than this will be pathological. Coming to the first degree AV block, we can say that this is a misnomer because there is no block per se, but there is constant prolongation of the PR interval. We'll study with the help of a diagram. This is the normal conduction of the heart. But if there is some pathology at the level of AV node, that AV node is not conducting at the normal pace but is conducting at a slow rhythm, so there will be a constant prolongation of the PR interval, but it will be constant. It will not increase, it will not decrease, it will be prolonged. So we can say the first degree AV block is in which the AV block is just prolonged. There can be multiple causes of first degree AV block, like the increased vagal tone. What do I mean by increased vagal tone? It means the increase in the parasympathetic system. The parasympathetic system in our body is supplied by the vagus nerve towards the heart. So those who have high vagal tone, for example athletics, will be having a constant first degree AV block. Then drugs like the beta blockers, which inhibit at the level of SA node and AV node, will also be having first degree AV block. Hypothyroidism. In hypothyroidism, everything is getting slowed in the body. The BMR is slow, the heart rate is slow, so we will be getting first degree AV block. Infiltration like sarcoidosis, amyloidosis, that will be infiltrating in the AV block, giving us the first degree AV block. Usually the people with first degree AV block are asymptomatic and will have a good prognosis. The treatment is to revert the baseline disorder without giving any pacemaker. So this was the first degree AV block. Now coming to second degree AV block. We have two rules to study second degree AV block. The first rule is more than 2 P waves should be conducted. It means whenever we see a ECG, we should be able to notify that more than 2 P waves should be conducted and only 1 P wave should be missed. We'll remember this and then we'll study forward. Coming to second degree type 1. In type 2, we have two types. In second degree AV block, we have two types, type 1 and type 2. Coming to type 1 AV block. Coming to this diagram again. In this, the AV node is highly tired, highly fatigable. So what will happen? This is AV node. This is the first impulse that has come towards the AV node and it will send it to ventricles in a normal speed. But as the AV node is super tired, the second impulse will be slower than the first one and then it will be given towards the ventricle. The third conduction will be even slower than the second one. The fourth will be slower than the third one. And finally, the conduction will not be done via the AV node. So this will be missed. So what will we see? We will see that there will be a gradual progression, gradual elongation of the PR interval. And when this P wave is missed, the next P wave will be of the normal interval than the first one. We will understand this with the help of an ECG. This P wave is having normal PR interval, but then the next PR interval is prolonged and the third PR interval is prolonged even more than the second one. But this fourth P wave is missed because the AV node got so tired that it could not conduct this P wave and there will be a pause. So this is type 1 second degree AV block. So there will be a gradual prolongation. Whenever you will see a group beating. All these three QRS complexes will give us the assumption that they are beating together. Like these three are beating together, these three are coming together. So this is known as group beating. There will be variable RR. The RR distance will be variable because there will be a variable PR interval. Due to variable PR interval, there will be variable RR distance. Coming to causes, the causes can be the most common causes acute coronary syndrome, that is inferior wall MI. In the inferior wall MI, the right coronary artery is getting occluded. As we know, right coronary artery supplies our AV node. So whenever we have the occlusion of the RCA, the AV node will be going under ischemia. So there will be type 1 second degree AV block. Then drugs like beta blockers and diseases which causes edema of the AV node, again Lyme's disease, myocarditis, they all will lead to type 1 second degree AV block. In this, if the patient is asymptomatic, we have to just wait and watch and need not give any pacemaker. We just need to treat the baseline disorder. If it is drugs, we can withhold the drugs. If it is MI and inferior wall MI, we can treat the MI. If it is myocarditis, we need to give supportive management. But if the patient is symptomatic, then we can either give temporary pacing until the baseline disease resolves. If the baseline disease does not resolve, then we can give a permanent pacemaker as well. But that is less required in the condition of type 1 second degree AV block. Also, you will notice that in this ECG, all the QRS complexes are narrow. They are not wide because the pathology was at the level of AV node, and when the conduction was missed, the next conduction was happening through this route only. So all the QRS complexes were narrow. On the contrary, coming to second degree type 2 AV block, we will understand this now. In second degree type 2 AV block, there is already a baseline bundle branch block. Patient is already suffering from either a left bundle branch block or a right bundle branch block. In this figure, I have taken a patient who is suffering from underlying right bundle branch block. So the baseline ECG of this patient will be having normal PR interval, but the QRS complex will be broad because of LBBB, and the normal conduction will be happening through this route. This is the baseline conduction. But due to some reason, when this left bundle will be gone, there will be a transient withhold of the impulse. The impulse will not be conducted from the atria towards the ventricles, because in this a wave was coming via the left bundle branch block. But due to some reason, if this bundle is also gone, so the conduction will not be happening from atria to ventricles. As seen in this image, the type 1 was having issue at the level of AV node, but the type 2 is having issue at the level of bundle of His or at the level of bundle branches. In this type 2 second degree, the PR interval will be normal and will be same throughout. Only one P wave will be missed. We'll see, this P wave was conducted, this one was conducted, this one was conducted, but this one was missed. If you will see, the PR interval after this P wave and the PR interval before this P wave are same. So this is a type of type 2 second degree AV block. How can we differentiate between type 1 and type 2 at a glance? We can differentiate by localizing the P wave which was missed. In this we have localized that this is the P wave which was missed. The PR interval before this and the PR interval are after this are equal. But if the PR interval after this would have been shorter, then this would have been type 1 second degree AV block. But just because they are same, that's why this is type 2 second degree AV block. In this also, more than 2 P waves are conducted and only 1 P wave is missed. This is our normal protocol of the type 2 second degree block. More than 2 P waves are conducted and only 1 P wave is missed. These were the 2 rules that we have studied before going into second degree AV block. Type 2 second degree AV block is more dangerous than the type 1 second degree AV block because there is already some underlying cardiac issue from which the patient is suffering. Again, in this ECG, this P wave is conducted, this P wave is conducted, but this is not conducted. So more than or equal to 2 P waves are conducted and only 1 P wave is missed. So this is, and the PR interval is same before and after the P which was missed. So this is type 2 second degree AV block. Both SA node and AV node are influenced through sympathetic and parasympathetic both. But the intraventricular conduction is only affected by the sympathetic, not the parasympathetic. So in type 2 second degree AV block, there will be no response to atropine. The causes of second degree type 2 AV block is the underlying sclerosis of the bundle branches, the infiltration of the bundle branches, or the neuromuscular dystrophy or atrophy. Type 2 second degree AV block usually requires permanent pacemaker because the damage is permanent throughout the bundle branches. So this was the type 1, the defect was at the AV node, therefore the QRS complex was narrow. In the type 2 second degree AV block, the defect was infranodal at the His bundle or at bundle branches, so the QRS complexes were broad. Now coming to this ECG, let's study. One P wave is conducted, one is not. One is conducted, one is not. Can we call it a second degree AV block? Because we have studied in to call it a second degree AV block, 2 or more P waves should be conducted. So that rule is not being met here. So this is not the classical second degree AV block. This is a special type of second degree AV block known as 2:1. What do I mean by 2:1? 2 is the number of P wave which is conducted and 1 is the number of QRS which is coming. So P/QRS is 2:1. In this, I cannot say whether it is type 1 or type 2 because to call it either a type 1 or type 2, I need to have consecutive 2 PR intervals so that I can match whether the PR interval is prolonging or is it constant. But in this ECG, I cannot compare any 2 consecutive PR intervals. So this is a special type known as 2:1 degree AV block. So now coming to the last type of AV block, that is third degree AV block. In third degree AV block, the AV node has been transected completely. Not even a single impulse is going from the SA node to AV node and to ventricles. The SA node is beating at its own pace and the ventricles are beating at its own pace. If the defect is at the level of AV node, the next impulse will be coming from bundle of His. So the SA node rate will be 72 per minute and the bundle of His rate will be 50 per minute. But if the defect is at the level of bundle of His, so the escape rhythm will be coming from ventricular muscle, so that will be 40 per minute. The escape rhythm which will coming from bundle of His, that will be narrow. The escape rhythm which will be coming from ventricles, that will be broad. So just by seeing the ECG, we can tell the AV nodal block, third degree AV nodal block, whether it is nodal or infranodal. If it is narrow, if the QR complex is narrow, it is at the level of AV node. If the QRS complex is broad, then it is the level of infranodal block. In this, the atria will be beating at its own rhythm, at its own pace, and the ventricles will be beating at its own pace. There will be AV dissociation, and there will be difference in all the PR interval. This is P, this is P, this is P, this is P, this is R, this is R. The R will be same and P will be same, but there will be no relation between the P and the R. We'll study this by an ECG. See, this is RR distance. If you see, RR distance is same, but there is no relation between P and R, and PP distance is same. PP, the one P wave must have been buried inside this QRS. The PP distance is same. So RR will be same, PP will be same, but there will be no correlation between P and R. Similarly, the PP is same, RR is same, but there is no correlation between P and R. If you will see, this is a case of inferior wall MI. There is elevation in second, third and AVF, inferior wall MI. Because RCA supplies the AV node, so the patient has gone into complete heart block due to the inferior wall MI in the leads 2nd, 2 and 3. 2nd, 3rd and AVF. So now come to the summary. In first degree, there will be constant elongation of the PR interval, but no P wave will be missed. In type 1 second degree, there will be gradual prolongation of the PR interval, and then the P wave will be missed. We can check by the PR interval before and after, they will not be same. We see group beating in this, we see variable RR in this, and the QR complexes are narrow. In type 2 second degree, the PR interval will be constant, but suddenly a P will be missed. The PR interval before and after will be same, and the QRS complexes will be more likely broad because the patient is already having some bundle branches block. One is conducting, one is not, one is conducting, one is, this is 2:1. This is a special type of second degree AV block. In this is not conducted, this is not, but this is. This is not, but this is conducted. This is 3:1 special type of second degree AV block. This is third degree AV block, in which there is no relation between P and R. The PP is coming at its own pace and the RR is coming at its own pace, but the difference is narrow and broad. In this ECG, the defect is at the AV node because the QRS complex is narrow, more likely coming from the bundle of His. This is the defect is at the infranodal because it is QRS and more likely coming from the ventricles. So I hope this video was helpful to you. Try to get in the habit of looking at more ECGs so that the AV blocks will become more easier to you. Thank you.